Hey everybody, my name is Brian Jaros. I'm one of the fellows from Northwestern University in Chicago, and I'm coming here from RWCS to present my poster, which is a mastery learning-based curriculum for the instruction of knee arthrocentesis for internal medicine residents. So this workshop was born out of an issue that we're all pretty familiar with, which is the rheumatology workforce shortage. So many of you know the 2015 Workforce Committee came out and said by 2030 there's a projected supply to demand mismatch of over 100% with a shortage of available providers. So a lot of solutions have been thrown around in terms of offloading rheumatology demands, and one of those is empowering our internal medicine and primary care colleagues to help us address common musculoskeletal complaints, which we know are really frequently seen in their office. And a skill that's kind of imperative to addressing some of these complaints is arthrocentesis. Now, this used to be a skill that was routinely taught in internal medicine residency. I can say from my training, certainly that kind of has fallen out of favor and is no longer an ACGME requirement, but we're trying to get it back in there and get internal medicine residents excited about this skill that's honestly very useful and practical for them to know. So this workshop we're creating is using a simulated knee model to try to instruct these internal medicine residents on how to perform a diagnostic and therapeutic arthrocentesis. Similar simulation models have been performed in the past, but they suffer from a common problem, which is poor retention of the skill long term. So while the workshops are effective in the short term, when they're retested at 6 or 12 months down the line, learners often can't perform that skill independently. Our practice is a little bit differently because we're employing an educational technique or theory that actually came out of Northwestern called mastery learning technique. And this is the idea that any person, any individual with enough time, coaching, deliberate practice, and feedback can become the master of any skill when it's broken down into small, kind of attainable parts. This has been shown in the critical care literature to be really effective for durable central line placement skills, and so we're hoping to incorporate that into arthrocentesis. So the way this works is we'll recruit internal medicine residents at Northwestern. We'll ask them to be part of our study, but they'll get offered the curriculum no matter what if they do or don't participate. They'll get kind of a pre-evaluation to see at baseline if they're able to perform the arthrocentesis skill, and also perform kind of like a written knowledge exam so that they don't just know how to perform the skill, but other aspects like why you would perform arthrocentesis, when it's safe to perform it, when it's not safe to perform it, and other aspects. Then the residents will undergo a workshop. They'll get kind of a multimodal didactic with both a PowerPoint component and instructive hands-on teaching using a simulated knee model, which you can actually fill up with fluid. It has a fake bladder that represents the synovial cavity. It has true bony landmarks of the patella, the tibia, the femur. So it's a really cool replica of an actual knee. And they'll get to practice themselves over and over and kind of get comfortable with accessing that joint space. We'll bring them back at a later time point and then test them on a very particular checklist of steps that they need to accomplish in order to have mastered the skill. And the end goal will be for everyone who takes the course to master the skill. They might master it on the first try a week later, or they might not master it at first, need to go back to a workshop phase, again, be paired with a master in this area who can continue to coach them, teach them more until they're able to accomplish those steps independently. Here in this figure, I can show you an example of the knee model that we're using. You can see on the left here, it's a knee that's almost in full extension, similar to the way we would perform medial parapatellar large volume aspiration in the clinic or in the hospital. And here's a picture of me accessing the joint space about 2 to 3 finger breadths below the patella, again, similar to like we would do in real practice. And kind of to summarize everything I've said, you can see here in the study process map everything I've talked about thus far. So we'll enroll the students, we'll have them take a baseline exam, they'll participate in the workshop, and they'll continue to do that until they achieve what we call MPS, the minimum passing standard, which shows that they've achieved mastery. And really the outcome will be, can they perform and continue to achieve mastery at further outcomes at 6 and 12 months. So we're hopeful that this is the first look at using mastery learning in our rheumatology field, learning from our critical care colleagues and our medical education colleagues, and hoping again to just empower our internal medicine trainees and get them excited about arthrocentesis. So thanks for listening to me, and have a good day.